So today's topic will be on the chronic kidney disease in type 2 diabetes. What are all the challenges we are facing it, and what are all the progress and the possibilities of the management of the different drugs. So in the next few minutes, I would like to talk on epidemiology of the diabetes, epidemiology of CKD, type 2 diabetes and its association with the CKD, significance of addressing the CKD in type 2 diabetes, why should we address it, what is the pathophysiology of the CKD in the type 2 diabetes, the challenges and the limitations in diagnosing the type 2 diabetes and CKD, management of the CKD, finally few points on the prevention and also the novel therapies and approaches. You are familiar. You are all familiar with the epidemiology of the diabetes. The one thing is very clear here. If you see here, in 2019, there are about 7.7 crores of the Indians are having the diabetes. Their projections in 2019 is by 2045, we will be having about 13.4 crores. But the reality is, we already reached the 10.1 crores by the year 2023, last year. So if your projections earlier is about 13 crores by 2045, and already we reached the 10 crores by 2023. So that shows that the incidence of the diabetes is increasing in a tsunami proposition. It is a very high rate. The prevalence of the diabetes is increasing, and the incidence is also very much increasing in Indian population because of the several environmental factors. You all know those all environmental factors like physical inactivity, etc. And what about the CKD? CKD, about 1 in 3 adults with the diabetes is having a chronic kidney disease, and 1 in 5 adults in the high blood pressure is having a CKD. What are all the factors responsible for the CKD are individuals with hypertension, elderly individuals, individuals with the diabetes mellitus, and some racial, especially the Asians, are at the high risk of getting the CKD. In India, the diabetes and hypertension account for about 60% of the CKD cases, and if you take the Godavari districts, I think nearly 75 to 80% of the CKD is because of the diabetes and hypertension. And ICKD study showed nearly the 40% of the diabetic patients had the CKD. So a very high number of our type 2 diabetics are getting the CKD in the near future. So what is the significance of addressing the CKD in the type 2 diabetes? One is a high prevalence because the disease is type 2 diabetes is very high in Indian population, and the type 2 diabetes converting to the CKD is also very high in our population. So we have to address this high prevalence of this disease, and also the increase in morbidity and the mortality. So you know that the CKD is at risk of the cardiovascular diseases. If left untreated, will end up with the ESRD. So they need the renal replacement therapy, either in the form of the dialysis or the transplantation. And these people, they die prematurely because of the aggressive atherosclerosis and the myocardial infarction. So the type 2 diabetic patients with the CKD have a higher rate of adverse outcomes compared to those without the CKD. And the progression of the kidney disease. Unfortunately, we have a marker like microalbuminuria, but unfortunately, most of type 2 diabetes, they don't get this test. So this microalbuminuria will convert to the macroalbuminuria, and slowly the elevation of the creatinine levels and the CKD. So the managing the type 2 diabetes effectively can help the slow down the progression of the CKD and delay the need for the renal replacement therapy. And another important point to address here is the cardiovascular protection. So you all know that the most of the type 2 diabetic people, the commonest cause of the death is the cardiovascular disease. And again, in the CKD population also, they die in the hands of the cardiologist because of the ischemic heart disease or the arrhythmias or the heart failures. So the managing CKD is an independent risk factor for a cardiovascular disease, and type 2 diabetic patients with CKD are at even higher risk. So managing CKD, the risk of the cardiovascular events can be reduced so that we can prolong the quality of the life. We can give the quality of the life to this population if you protect the cardiovascular systems. And finally, by addressing the CKD much early in the type 2 diabetics, we improve the quality of the life in these individuals. So these are all the risk factors for the diabetic kidney disease. They are the risk factor. There are some people are susceptible. In some individuals, there is initiation of the CKD, and in some individuals, the progression of the CKD is also much higher. If you take the old age, so those people are more susceptible to have the CKD, and the male people are more prone for the CKD. The race, the Asians or Indians, are both at the susceptible and as well as the progression. Suppose if the Asian gets the CKD, the progression is very fast. And family history of the DKD. So diabetic kidney disease runs in the families. And the genes, genetic kidney disease also, there is a big initiation to cause the CKD. And of course, hyperglycemia, that is diabetes, obesity, hypertension. They are all the risk factors to get the susceptible initiation and much progression of the CKD. Kidney injuries like AKI caused by your snake bite poisons or toxins, etc., or analgesic nephropathies, etc. So they are again an initiation of the progression of the CKD. Some toxins, smoking is a big risk factor to progress the CKD. So all the CKD population we advise not to smoke. And dietary factors like high protein intake is more susceptible as well as the progression. But in India, as the most of our diets are deficient in high protein diet, so we can continue the normal protein diet in our Indian CKD population. If you see the pathophysiology of the diabetic kidney disease, so there are the several factors are there. One is the glomerular hypertrophy. There is the increased oxidative stress, the tubular inflammation, renal fibrosis, mesangial expansion. So these are all the changes, the pathophysiological changes that occur in the kidneys to cause the DKD, that is the diabetic kidney disease. So there is a defect in both the structure as well as the functional abnormalities. So structural abnormality in the form of your albuminuria or your glomerular hypertrophy or mesangial expansion or renal fibrosis, these are the structural changes. The functional abnormality is your reduction of your GFRs. So then lead to the progression of the loss of the renal function. It typically manifests as the microalbuminuria. So the normal albumin excretion is up to the 30, and 30 to 300 is the microalbuminuria. 300 to 500 is the macroalbuminuria. So first micro, then the macro, and then the proteinuria more than the 500. And finally, there will be the declining in your GFR and increasing in your creatinine levels, and left untreated, these people will end up with the end-stage renal disease. See, unfortunately, most of these people are asymptomatic. Microalbuminuria is asymptomatic, macroalbuminuria is asymptomatic. Even the declining the GFR up to the 15 or the 25 or 30, they are the asymptomatic. So the beauty of the disease here is we have to pick up the CKD at an early time in an asymptomatic manner so that we can give good quality of the life by arresting the progression of the CKD. See, this is the picture which shows you the normal glomerulus and the diabetic kidney disease. See here, you can see the podocytes, you can see the foot processes, there will be the glomerular basement membrane, and if you see the second picture, you can differentiate that there will be the thickening of the glomerular basement membrane, there is the fusion of the foot processes, loss of the podocytes. This is a very important cell in the glomerulus to cause the diabetic kidney disease. Here the loss of the podocytes, and then there will be the thickening of the glomerular basement membrane, and then the mesangial matrix expansion. See, all these things are the changes, pathophysiological changes that occur in the kidney because of the uncontrolled hyperglycemia and hypertension. See, what are all the mechanisms leading to kidney damage? As I told you that podocyte injury, the podocytes play a crucial role in maintaining the glomerular filtration barrier. So hyperglycemia and inflammation contributes to the podocyte injury so that there will be the reduction in the filtration functions. The renal inflammation is another important pathophysiology. So there is a persistent hyperglycemia triggers the inflammatory responses within the renal tissue, and infiltration of these immune cells and the pro-inflammatory cytokines. So these contribute to the kidney damage. And then the glomerular hypertension. So uncontrolled diabetes hyperglycemia. This induces the glomerular hypertension, leading to the increased intraglomerular pressure and subsequent damage to the filtration barrier. So the glomerular hypertension will cause the damage, podocyte injury will cause the damage, renal inflammation will cause the damage, and finally the fibrosis. So the chronic inflammation and oxidative stress promote the renal fibrosis, causing the structural alterations in the kidney and impairing the function. And finally, the kidney size will be reduced in the presence of the ESRTs. The same thing here, the diabetes, hypertension, dyslipidemia, etc. So there's a different hemodynamic, metabolic, inflammatory, fibrotic factors alteration will be there. And finally, there will be the nuclear factor KB is a key modulator of the inflammation in the diabetic kidney disease. And finally, because of this increase in this nuclear factor KB leads to the glomerular hypertrophy, mesangial expansion, glomerulosclerosis, fibrosis, and tubulointerstitial fibrosis and inflammation. And finally, diabetic kidney disease. So what are the challenges and the limitations in diagnosing the CKD in the type 2 diabetes? See, the first limitation point is the asymptomatic nature. See, unfortunately, most of our people, they visit the doctor only when they are symptomatic. But unfortunately, the CKD, even at the stage 4, and some people even at the stage 5, they are asymptomatic. Even at the creatine 6 and 7 and 8, they are asymptomatic, some population. So CKD in its early stages is often asymptomatic, leading to delays in the diagnosis, as the patients may not seek the medical attention until the significant renal damage has occurred. So it is our duty to pick up the CKDs in an asymptomatic nature so that we can arrest the progression of the diseases. And what about the influence of the glycemic control? So there are the fluctuations in the blood glucose levels, that is the glycemic variability. So this glycemic variability can impact the kidney function measurements, making it challenging to discern the effects of the diabetes from those of the CKD. Whatever the variability in the estimated GFR. So the commonly used GFR equations may have the limitations in the accuracy, especially in the diverse population. So we have the lot of the calculations for the GFR. So ethnicity, age, muscle mass, these are all can affect the reliability of your GFR values. What about the urinary albuminuria measurements? See, albuminuria is a key marker for the early renal damage. However, the variations in the urine collection methods and other factors can affect the accuracy of the albuminuria measurements. So these are all the limitations in our diagnosing the CKD. Maybe asymptomatic nature, glycemic variability, and variability in the GFR estimations, and urinary albuminuria measurements variability is these are all possible things. So this is a very good slide, shows you the hyperglycemia. So there will be the cellular injury, mesangial expansion, etc. and etc. And the GFR high, normal, low, and finally the ESRD. And if you take the microalbuminuria, macroalbuminuria, etc., hypertension, cardiovascular diseases, kidney complications, so these are all occurs when there is a microalbuminuria. So the microalbuminuria is a reversible, whereas the macroalbuminuria or the albuminuria or the elevated creatinine levels is irreversible. So whatever the help we are going to do the diabetic patients is pick up the CKD in the early stages so that we can postpone the onset of the end-stage renal disease in most of these individuals. So microalbuminuria much earlier than the GFR reduction. So these are all the factors related to the therapeutic inertia and the DKD. So they are the physician inertia, maybe because of the lack of the supporting staff, concerns about the treatment costs, so lack of knowledge, etc. And the patients, a lot of the patient factors are there on the healthcare systems. So these are the different inertia, especially the countries like India. So a lot of the people are having the DKD. So because of the patient barriers, physician barriers, and the healthcare system barriers, we are losing a lot of the patients of the CKD prematurely. So how to diagnose the diabetic kidney disease? So the two factors are very, very important to know the kidney function and the kidney damage. So either of these following present for more than the 3 months, you consider as the diabetic kidney disease. So the markers of the kidney damage is albuminuria. So this is the urinary albumin excretion ratio, creatinine and urea, albumin creatinine ratio. So more than the 30 milligrams per gram is a positive for your kidney damage, and the GFR less than the 60 is a marker of the kidney dysfunction. These two should be present for more than the 3 months to consider the fellow is suffering with CKD or the DKD. See, this is the diagrammatic. It shows you one side there is the GFR declining depending on the patient's uh, control of the blood sugars. On the other hand, elevation of your albuminuria. So these two are very, very important factors to assess the patient's continuation and the severity and the progression of the CKD. So we should reduce the albuminuria in all our population, and we should see that the GFR should not decline very fast to reach the stage of 15 or the less than the 15 to consider the ESRT. So this slide, if you see here, if the GFR, on the one side is the GFR and the other side is the albuminuria, and we all know that the GFR is more than 90 is the normal population. And if you consider that only the GFR, you see that when the GFR is 92 or 94, we say that you are having the normal kidney function. But suppose if you add the albuminuria also, if the fellow is excreting more than the 300 milligrams per gram of your urinary albumin excretion ratio, so then this fellow will comes under the high risk individual. So to assess the CKD prognosis, we have to see both the kidney function as well as the albuminuria. What is the importance of the early detection? So we can prevent the progression. We can assess the cardiorenal syndrome. It's a very, very important, because I told you that early detection enables the implementation of the strategies to manage the cardiorenal syndrome. So whether the patient is having the heart failure or the ischemic heart disease or cardiomyopathy, etc., to reduce the risk of the cardiovascular events and reducing the healthcare costs also. If you detect these things much early, so definitely our interventions also will be low. What about the prevention and the treatment? See, multiple strategies are now available to slow the diabetic nephropathy progression. Prevention of the kidney disease remains the crucial. In spite of your ACE inhibitors or ARBs or the statins or the low protein diet, etc., but still the kidney disease remains very, very crucial in most of our population. The risk of developing the diabetic nephropathy is particularly reduced by achieving and maintaining the good blood glucose and the blood pressure control. It is very easy to say that the blood pressure and the blood sugar should be under target levels, but it is very, very difficult to reach, especially in the CKD population, because this CKD population are at high risk of hypoglycemia, and at the same time, these people are really having a accelerated hypertension. Sometimes, hypertension urgency or emergency is also very common in the CKD. You have to use many drugs to control the blood pressure. See, these are all the promoters of the progression of the diabetic nephropathy. The metabolic syndrome, you know what you mean by the metabolic syndrome, a combination of the diabetes, hypertension, obesity, and dyslipidemia, more protein intake, more smoking, some genetics, oxidative stress, fibrosis, vascular inflammation or the renal inflammation, systemic and intraglomerular blood pressure, RAS activity, albuminuria, uncontrolled diabetes, uncontrolled lipids, obesity. So these are all are important factors to cause the diabetic nephropathy or the CKD. So to have a normal kidney function, we have to address all these things. So metabolic syndrome addressed by your approach, dietary approach and exercise. So protein intake, not of much non-vegetarian protein, more of the vegetable protein here. Smoking has to be cessated. We can't change our parents and the genes. So genes, we can't do anything. Oxidative stress, definitely good sleep, good meditation, etc. We can reduce the oxidative stress. So then the inflammation and systemic intraglomerular pressure, all these by controlling your diabetes and hypertension, RAS activity by using the ACE and ARBs, albuminuria by using the ACE and ARBs, glycemic control with your insulin or the definite OHS, as our chairperson is saying that there we have to adjust the lot of the OHS in the CKD population. Dyslipidemia, we have to use the statins. If you want to add the fenofibrate, so to reduce the hypertriglyceridemia, and fenofibrate may increase the creatinine level. So combination of the statin and fenofibrate is much known. In the presence of the CKD, we have to use the maximum dose of the statins in this population. And obesity has to, the weight reduction must be there in all the CKD population to have a normal renal function. So this is a very, very important. KDIGO emphasizes the management of all these things. What about the glucose control? See, if you have the control by conventional insulin therapy and intensive insulin therapy, by intensive insulin therapy, you can have a reduction in the moderate elevated albuminuria, severely increased albuminuria, and also the GFR restrictions, ECK progression also can be reduced with the intensive insulin therapy. See, this is a very good slide, shows you the lifestyle therapy of the management of the CKD. So physical activity is good, nutrition is very important, weight loss if the patient is overweight and the obesity, and then coming to the drugs in the diabetes, as far as the diabetic kidney disease is concerned, the metformin. So we all know that metformin is a very, very important drug to be used in the diabetic individuals, but you have to respect the GFR to adjust the doses of the metformin. If the GFR is less than the 30, we have to discontinue or stop using the metformin. If the GFR is more than the 60, you can continue the same dose of the metformin. If the GFR is between 30 and the 60, we have to reduce the dose of the metformin. That is the very important. In end-stage renal disease, we have to discontinue or stop the metformin, because end-stage means less than the 15. Even at the 30 also, we have to stop the metformin. And coming to the SGLT inhibitors, very, very important drugs to be used in the CKD. But again, depending on the GFR only, when the GFR less than the 30, we have to stop using the SGLT inhibitor. So that means your creatinine level is above 2.5 or the 3 or the 4. So that is time we have to stop using the SGLT inhibitors. Again, in the kidney failures, don't use the SGLT inhibitors. Otherwise, these people will have the diabetic ketoacidosis and also more and more lactic acidosis, etc. Some drugs like GLP-1 receptor agonists, if the patient is obese, they are all preferable drugs. DP4 inhibitors are very useful in CKD, especially the linagliptin. So you can continue the same dose of linagliptin. All the gliptins are also useful in the DKD, diabetic kidney disease. But linagliptin can be used without adjustment of the dose, whereas other gliptins you have to adjust the dose according to your GFR. Insulin is the best drug to be used in the DKD, but at the cost of the hypoglycemia. So you have to address the hypoglycemia when you are using the insulin, especially you have to use the shortest acting insulins which don't cause the hypoglycemia for a prolonged periods. So the analog insulins are preferable here, and the basal insulins are preferable here, not to have the hypoglycemia. Sulfonylureas, we don't use the sulfonylureas in the DKD, but if you want to use the sulfonylurea, the shortest acting sulfonylurea like the glipizide is ideal in the DKD population. Thiazolidinediones, you can use up to the creatinine of 3 or 3.5, but these thiazolidinediones like pioglitazone, they cause fluid overload, they cause obesity, they precipitate the heart failures. So you have to use the pioglitazone in some cases with the DKD. If the people are more prone for the heart failure, so definitely have to stop using the thiazolidinediones like pioglitazone. Alpha glucosidase inhibitors, they are good drugs because they act only at the level of the intestines. But CKD population will have the nausea, vomiting, abdominal pain, etc. So again, the alpha glucose inhibitors also may cause these side effects. So better to avoid these drugs if the patient is having gastrointestinal symptoms. Long-term intensive glycemic control is established in preventing the CKD, particularly in the early stages of the diabetes. Is a very, very important intensive glycemic control. That means you have to keep the fasting blood sugar around 100, PP blood sugar around 150, and HbA1c maybe around 7. So that is the ideal way of keeping the A1s in the DKD population. Suppose if you want to keep the A1c at about 6.5, definitely you are inviting the hypoglycemia, and hypoglycemia is much more dangerous than the hyperglycemia in CKD population. SGLT inhibitors are very, very useful drugs. These are the different studies. EMPA-REG with empagliflozin, CANVAS study with the canagliflozin. Nowadays we are not using the canagliflozin for the fear of the peripheral vascular disease or Horner's gangrene or amputations, etc. We use either the DAPA or the EMPA as the drugs of the choice for the DKD. Dapagliflozin, you have the beautiful study, DAPA heart failure and the DAPA CKD, and empagliflozin emperor. All these studies clearly says that SGLT inhibitors are very, very, very useful drugs to be used in the CKD population along with the heart failure also. So initiation of the pharmacological treatment for hypertension is very, very important, because a combination of the hypertension and the diabetic, hypertension you have to treat very aggressively, otherwise all the diabetic complications will be multiplied in the presence of uncontrolled blood pressure. So ACE and ARBs are your drugs of the choice, but again, check the potassium levels to adjust the doses of these ACE inhibitors or ARBs. Otherwise, these people will have the hyperkalemia because of the CKD and also because of the ACE and ARBs, and then they will cause lot of the cardiac manifestations. Effect of the intensive blood pressure control and the cardiovascular outcomes in the diabetes. I told you that lot of the drugs you have to use to control the blood pressure here. So as the creatinine is beyond the 2 or 2.5 or the 3, we have to stop using the ACE or ARBs. The drugs of the choice here are the calcium channel blockers like your nifedipine, 20 milligrams TID, or your amlodipine 10 milligrams BD, or cilindipine 10 milligrams TID or 20 milligrams PD. So you have to use the maximum doses of the calcium channel blockers here. We have to add the loop diuretics once the GFR is less than the 30, maybe the torsemide or the furosemide. We have to use the alpha blockers like the prazosin, your mini-press XL, maybe 2.5 milligrams is the initial dose. You have to uptitrate the doses to 5 milligrams TID or the 10 milligrams TID. You have to use the central acting drugs like artemisinin here. So these are all the different, you can use the beta blockers like the bisoprolol here. So some people, I think at least more than the 50% of the CKD population, they need calcium channel blocker, they need the loop diuretic, they need the central acting drug, they need the alpha blocker, they need the beta blocker. I think the CKD is the one subset of the population where we have to use the maximum number of the antihypertensive medications. Most of these people are resistant hypertension. So this is a good slide, shows you that all patients, they need exercise, nutrition, cessation of the smoking, ABC, that is your glycemic control, blood pressure control, and the lipid control. And most of the patients, they need RAS inhibitors, RAS blockade, your telmisartan or olmesartan, etc., and SGLT inhibitors. And some people, they may need antiplatelet agents. What are the novel therapies? They are the glomerular hyperfiltration and inflammation, fibrosis. They have been a major focus for the development of the new treatments. So this is the drug of the choice for today's talk. Finerenone, a beautiful drug, a novel drug, a non-steroidal selective mineralocorticoid receptor antagonist. So you have the aldosterone. So that is also a mineralocorticoid receptor antagonist, but that is a steroidal. It is not a non-steroidal. So the finerenone is a non-steroidal and bulky, and the unique structure results in the selective and the potent interaction with the mineralocorticoid receptor and regulation of the gene expression, and it exhibits anti-fibrotic and anti-inflammatory effects. So that's how the finerenone is making a very good drug, almost like a game changer in the management of the diabetic kidney disease. So it is available in the form of the 10 milligrams and the 20 milligrams. So 10 milligrams you can start when the GFR is less than the 30, and 20 milligrams when the GFR is above 30, maybe 30 to 60, you can use 20 milligrams, and less than the 30 you can use the 10 milligrams. It is indicated in the adult patients with the CKD to reduce the risk of sustained GFR decline, end-stage kidney disease, a cardiovascular death, non-fatal myocardial infarction, and hospitalization for the heart failure. See the advantages of the reduction of all these things. See, these all will lead to the more and more morbidity and the mortality and hospitalization. So that can be controlled with the addition of the finerenone in all these CKD population. It is highly selective for the mineralocorticoid receptors. No off-target sexual side effects, unlike the spironolactone like gynecomastia, etc. Finerenone had a modest effect on the systolic blood pressure, and it has no effect on the HbA1c. So it won't cause any hypoglycemia. So this is the ADA and the KDIGO consensus recommendations for the pharmacological management of CKD. So there are important drugs to be used in the CKD. One is the metformin. So respect to the GFR. SGLT inhibitor, again respect the GFR, when it is less than the 30, stop using. GLP-1 receptor agonists, they are the very, very useful drugs. Statins, very useful. RAS inhibitors or ARBs, at least respect the hyperkalemia here. And finally, finerenone is a useful drug. It's a cardiorenal protection is seen here. An additional risk-based therapy for patients with the GFR more than the 25, normal serum potassium concentration, and albuminuria, despite a maximum tolerated dose of the RAS inhibitor. So these are the important drugs to be used in the DKD. Again, I'm saying that metformin is useful, SGLT inhibitors are useful, statins are useful, ACE or ARBs are useful, and finally, the finerenone is also a good game changer in the management of the diabetic kidney disease. So thank you very much for your patient hearing.